Hello everyone, we are back with our gynae series and today we will be discussing PCOS or Polycystic Ovarian Syndrome. Polycystic Ovarian Syndrome. It's a very vast topic and we will be discussing it in bits and pieces. Today I will be talking about definition of this syndrome and the pathophysiology. PCOS, some people used to call it as PCOD, that means disorder or disease, but nowadays we consider it as a syndrome and not disease. Before starting with it, I would like to tell you that it is also called as Steen-Leventhal syndrome. It was first described by Steen and Leventhal in 1935 and since then it is called as Steen-Leventhal syndrome, but right now we know it by the name PCOS or Polycystic Ovarian Syndrome. It is a common endocrine disorder. It is a part of gynecology, it is a gynecological disorder, it is an endocrinological disorder affecting women of reproductive age. It involves reproductive, metabolic and psychological disturbances. That's why I told you it is a very vast topic because it starts from some place and reaches at some other place. Why it matters? Why is it important to talk about PCOS? It affects around 8 to 13% of the women and it is a major cause of infertility. It is associated with diabetes, cardiovascular disease and endometrial cancer. So we need to know about it because it starts from reproductive age and till late part of the life it can affect so many systems. Now talking about the prevalence, as I told you earlier, 8 to 13% or around about 10%. That means 1 in every 10 women is affected with PCOS. It is such a high prevalence. 30% infertility is caused due to anovulation. If we see 100 couples who wish to conceive but are unable to, out of those 100, 30 will be having anovulation and out of anovulation 85 to 90% anovulatory infertility is due to PCOS. So PCOS is a major cause of infertility. Now there are some topics, some things, some terminologies that you need to know before starting off with the topic itself. Hyperandrogenism. What does that mean? Hyper means more. Androgen. Androgen is a male hormone, male dominant hormone. So presence of more of male hormones in the body is hyperandrogenism. Clinically, how do we find that the woman or the patient or the walking in person in your OPD chamber is having hyperandrogenism? By hirsutism. What is hirsutism? Presence of male pattern facial hair in a woman. Male pattern facial hair. What does that mean? This is the face of that lady. So, mustache area, beard area, chest area, you will find male pattern hair. This is hirsutism. This is the main clinical symptom of hyperandrogenism. Acne and alopecia, that means loss of hair, are secondary clinical features, but most important is hirsutism. Biochemically, by laboratory test, how do we know? Increased testosterone, increased DHEAS. What is DHEAS? Dehydroepiandrosterone. And these are the main androgens in our body. But most important is testosterone. And sometime androstenedione is also elevated. Now next terminology is ovulatory dysfunction. I have talked about it in much detail in my AOB classes, But here if we are saying ovulatory dysfunction, that means that the patient is having oligomenorrhea, means infrequent menses. Amenorrhea, what does that mean? A cycle length, intermenstrual cycle length of more than 35 days. Date doesn't come up to 35 days or less than 8 episodes of menses per year. Mostly a woman has 12 to 13 menses per year, but here this woman will have less than 8 menses per year. This is called as ovulatory dysfunction. Insulin resistance. The woman is having insulin in the body, but it is not working. It is a key factor in PCOS. I will be coming back to this thing later in the pathophysiology. You should know what is insulin resistance. Insulin in the body is not able to work. So, it leads to hyperandrogenism and acanthosis nigricans. Acanthosis nigricans are the changes of the skin in the body of a woman with PCOS which shows hyperandrogenism. We will be talking about all these in the clinical features. Now, what is the definition of PCOS? Definition of PCOS is highly confusing because there are many societies in this world which are talking regularly about PCOS, but they are not able to come down to a single consensus. So, there is something called as National Institute of Health, NIH. NIH in 1990 gave some criteria, then Rotterdam gave some criteria in 2003 which were gold standard up till now. There is something PCOS society which has given their own criteria, but nowadays in 2023 we have some international guidelines for PCOS or modified Rotterdam criteria, right? So, we will study about 4 things: NIH, Rotterdam, AE-PCOS and the international guidelines of PCOS, which is a common consensus which came in 2023 and which are the latest one. They are also called as modified Rotterdam criteria. What are they? NIH in 1990 said that if a patient demonstrates both of these things, then we can stamp that patient as PCOS. What are that? Clinical or biochemical hyperandrogenism, which I talked about in the previous slide. Clinical, that means you can see hirsutism, acne, alopecia. Biochemical means increased testosterone or increased DHEAS. So, the patient should have this, and ovulatory dysfunction, that means amenorrhea, oligomenorrhea in the absence of non-classical adrenal hyperplasia. Once you rule out non-classical adrenal hyperplasia and then both of these things are present, then we will say that the patient is having PCOS. Both of the points should be there. This is what NIH told. And then AE-PCOS told something else. We will be shifting to Rotterdam in 2003. In 2003, Rotterdam criteria came in which 3 things were discussed, and any 2 of these 3 criteria should be there. Till now, we were following these Rotterdam criteria. What are these? Number 1, hyperandrogenism, which is again the same, clinical or biochemical, which I have told already. Oligoovulation or anovulation, that is ovulatory dysfunction. Both of the things are similar. Third thing which they added was polycystic appearance of the ovaries on ultrasonography. What does that mean? The ovary doesn't have cyst, but small follicles are arranged in the periphery of the ovary, which you can see as cysts in the sonography. So, they are basically half developed follicles. which do not increase more in size because of the all hormonal disturbances, and then they get arranged in the periphery in a necklace pattern. So in ultrasound appearance, such appearance, polycystic appearance was mandatory in Rotterdam criteria, any two, right? So they counted the number, presence of 12 or more follicles. The diameter of each follicle should be 2 to 9 millimeter. That means it should not cross 10 millimeter diameter. On day 2 or 3 of menstrual cycle. So when did we do the sonography? On the 2nd or 3rd day of the menstrual cycle, and the follicle number was 12, cutoff was 12, and the volume of ovary was increased more than 10 ml in the absence of any dominant follicle or corpus luteum. If we understand the sonography, how do we measure the volume? We take the ovary in a whole and measure the volume. But what if the patient was having some dominant follicle at the time of examination? So in toto the volume will increase. So if we want to measure the ovarian volume, we always do the sonography on 2nd or 3rd day of the menses, so that neither there is any dominant follicle nor there is any corpus luteum. So the ovary is in the most dormant stage at that time, and the exact ovarian volume can be calculated. So what were Rotterdam criteria in 2003? Presence of more than 12 follicles and ovarian volume should be more than 10 ml. These were the criteria in 2003. But what happened next? Then we developed much better sonography machines. We developed transvaginal sonography machines. So with development of transvaginal sonography and better transducers, we were able to pick up more details of the ovaries. So this whole criteria got changed in 2023, and now they are labeled as modified Rotterdam criteria. So talking about modified Rotterdam criteria, which came in 2023 as a common international consensus. Diagnosis of PCOS is made by the modified Rotterdam criteria. 2 of the following 3 conditions have to be fulfilled. We need to remember these 3 conditions, and any 2 have to be fulfilled. Number 1, androgen excess, that is hyperandrogenism, ovulatory dysfunction, polycystic ovary morphology, PCOM, polycystic ovarian morphology. Morphology means appearance on the ultrasound. Now androgen excess. What they describe clinically, what? Same. Acne, hirsutism with a modified Ferriman-Galway score. What is Ferriman-Galway score? It is a scoring of hirsutism. The presence of facial hair, chest hair, hair over the body in a male pattern, and they give some scoring. So that score should be more than 8. A Ferriman-Galway hirsutism score of more than 8 is stamped as proper hyperandrogenism because of hirsutism. Acne and alopecia are also considered, but most important is hirsutism. Biochemical ones are elevated total or free testosterone. So we measure the testosterone either total or free. What is the difference between total or free? Total is ones which is free as well as bound with sex hormone binding globulins. Protein bound one is also calculated in total, but in free only the free portion of the testosterone is calculated. So elevated total or free testosterone, or there are some indices to measure testosterone, but in total testosterone is the most important marker. Other ones are DHEAS and ANSD, which I talked about earlier, dehydroepiandrostenedione and androstenedione. Ovulatory dysfunction, as I described, oligoamenorrhea, that means cycle length more than 35 days or less than 8 menses per year. Just remember this definition. Now PCOM, polycystic ovary morphology on ultrasound as per modified criteria. Why modified? Because we are now having a transducer of more than 8 megahertz and we are picking even those small follicles. So follicle number per ovary, FNPO, this is the way we describe the condition. FNPO of more than or equal to 20. Earlier it was 12. Now it is 20 because we are looking more precisely and more keenly. So now the cutoff is 20 in at least one of the ovary. FNPS, follicle number per section. So whenever you are moving your probe or transducer, you are looking up the ovary in a plane. In a single plane, the number of follicles should be more than 10. Now ovarian volume is the same, 10 ml. So the cutoff has changed from 12 to 20, but the ovarian volume remains the same, which is 10 ml. Now I am coming to the pathophysiology. Just have a look at this chart. First of all, I discussed about the definition and how do we define and say that yes, this patient is having PCOS, and there were criterias, there were hyperandrogenism, ovulatory dysfunction and PCOM. Now why does this happen? If we understand the pathophysiology, treatment becomes easy. This is a flow chart which tells you about the pathophysiology. Just have a look and I will come back to this again. Look at the hypothalamus, pituitary, ovary, adrenal gland and the adipose tissue. A vague look. Now, this is the way I describe a model for initiation and maintenance of PCOS. PCOS is a syndrome for life. We can only manage PCOS, we cannot treat PCOS because PCOS has got no other factor, no outside factor is doing PCOS. Internally there are changes inside the body and then there is a recurrent cycle and the body maintains that cycle and we need to break that cycle at some point. What is that? Alterations in pulsatile GnRH release. All of us know that what happens at puberty. At puberty, our hypothalamus starts giving pulsatile GnRH release. So there is a release, then there is a trough, release and trough. So this pulsatile release leads to something which creates menstrual function in the body. But alteration happens, that pulsatile release is no more there. So there is a relative increase in the LH, but FSH does not increase that much. So more LH in the body because of the alterations in the pulsatile GnRH release. And yes, FSH also increases but up till a point, but LH increases too much. So there is increase in LH FSH ratio. Now this LH stimulates the ovarian androgen production. What are the sources of androgen in our body? Ovary or adrenal gland. In this case, what LH does, LH acts on the theca cells of the ovary and more androgen is produced, while there is a relative paucity of FSH which prevents the adequate aromatase activity within the granulosa cell. Do you remember the two cell, two hormone theory? We have a granulosa cell, we have a theca cell, right? So what happens in theca cell, LH acts on it and forms the androgen. This androgen inside the granulosa cell is aromatized to estrogen, which is estradiol, which is a very potent estrogen. But here what has happened? More LH, relatively less FSH. So more LH has produced more and more androgen, but There is less aromatase activity because of less FSH, thereby decreasing the conversion of androgen to the potent estrogen, that is estradiol. Since there is less conversion of androgen to estradiol, we have a relatively excess androgen and relatively less estradiol, which is a potent estrogen. Now, increased intrafollicular androgen levels result in follicular atresia. Follicle needs that estradiol at that time to go for a positive feedback, for there is a release of progesterone. In our ovulation we have studied in the menstrual cycle. But because we cannot convert whole of the androgen to the estradiol because of less aromatase activity, that androgen gets accumulated inside that follicle and it leads to follicular atresia. That's why there is no ovulation. Increased circulating androgen levels contributes to abnormalities in the lipid profile of the patient and the development of hirsutism and acne. Increased androgen causing so many problems. Follicular atresia it causes, right? It causes changes in the lipid profile. Then what else? Hyperandrogenism has caused hirsutism and acne. Elevated serum androgens, primarily androstenedione, are converted in the periphery to the estrogen, but that is not estradiol, that is E1, estrone, which is not as potent as estradiol. So the patients of PCOS who are obese have much of peripheral adipose tissue. In the adipose tissue this conversion starts, androgen becomes estrone. So as the conversion occurs primarily in the stromal cells of the adipose tissue, estrogen production is more in obese PCOS patients. Conversion results in a chronic feedback at the hypothalamus as estrogen increases, but that is not the potent one. It is not estradiol, it is estrone. But that estrone causes a chronic feedback at the hypothalamus and the pituitary in contrast to the normal fluctuations, and this leads to a stage of anovulation. Earlier there was follicular atresia and now the feedback changes because of the presence of estrone in obese PCOS patient and there is anovulation. Unopposed estrogen stimulation of the endometrium lead to endometrial hyperplasia. In my talk of postmenopausal bleeding PV as well as endometrial hyperplasia, we have studied that it is always the unopposed estrogen where there is no progesterone. As we have seen, there is anovulation. So if you remember our menstrual cycle, if there is no ovulation, there is no corpus luteum, there is no progesterone in the body. Estrogen keeps on working on the endometrium and then there is endometrial hyperplasia. Now in PCOS, as I have told earlier, insulin resistance plays a major role. Why is it? Due to genetic abnormalities, some inherent genetic abnormalities. We have talked about the prevalence of PCOS, but PCOS in more in patients where the first degree relatives already had PCOS and or increased adipose tissue contributes to follicular atresia. So insulin resistance can be because of genetic abnormalities or because of increased adipose tissue. It leads to follicular atresia in the ovaries as well as development of acanthosis nigricans, furry appearance of the skin, that I will be talking in my clinical features class. So insulin resistance is very important, either because of genetic abnormalities or because of adipose tissue. Insulin increases, which leads to follicular atresia and acanthosis nigricans. So this syndrome may develop from primary dysfunction of any one of number of organ systems. There are number of organ systems: hypothalamus, pituitary, adrenal, ovary, adipose tissue. Anything at any place can go wrong and can lead to a cyclical pattern. The common denominator is development of a self-perpetuating non-cyclic hormonal pattern. Very important, self-perpetuating. It does not need any trigger. It starts and it maintains on its own. And it is a non-cyclic hormonal pattern. If it would have been cyclical, then it is a normal menstrual cycle. We know that menstrual cycle is a follicular phase, ovulation, secretory phase, back to that. But it is not like that. It is a non-cyclical pattern. So coming back to my flow chart now, I hope we understand it in a better way. From hypothalamus we start. So there is a change in the pulsatile GnRH pattern. Then the pituitary is stimulated and the LH and FSH ratio derange. LH is increased more and FSH does not increase more. In toto there is increased LH to FSH ratio. Now this LH is working on the ovarian theca cells to produce more and more androgens. Adrenal gland is also giving some androgen, but mainly it is coming from the ovary now. This androgen causes abnormal lipid profile, which I have told earlier. It causes an increase in adipose tissue, and in adipose tissue, the stromal cells, there is increased conversion to estrone. And this is a non-cyclical increase which causes an abnormal feedback on pituitary and hypothalamus, causing anovulation. And this estrone working on uterus causes endometrial hyperplasia. So changes in uterus is endometrial hyperplasia. This adipose tissue is also giving rise to insulin resistance, which is again causing a follicular atresia, and in skin hirsutism, acne, acanthosis nigricans. So there is a state of anovulation, amenorrhea, hyperandrogenism, ovulatory dysfunction. This is a self-perpetuating cycle of PCOS, and there are multiple sites to study: hypothalamus, pituitary, ovary, adipose tissue. With this, I am finishing off with my pathophysiology of PCOS. I hope you understood it in a better way now, and in the next lecture we will be talking about the clinical symptoms. Thank you so much.